Thank you, Klaus. Is that on? Yeah. Thank you. Good morning. Thanks, everybody, for getting up early on a Saturday morning. And Klaus, thank you for the last 3 days. It's been fabulous. I'm going to talk about teenage hip replacement, which hopefully is an infrequent event for most of us. But I think there's some special considerations when we talk about operating on the very young in terms of arthroplasty. So you've heard a little bit about this already this morning. These are challenging situations. We deal with various etiologies. We deal with morphology issues that are often not present in older, straightforward primary osteoarthritis cases. Often these patients have had previous surgery, especially in dysplasia and structural hip disease, which we see more and more of today. Patients have far different functional expectations in the very young than they do in the older population. We have to think about issues related to durability. And if you really look at the body of literature related to hip replacement, in the very young, there's quite a paucity of literature related to the results of and the surgical challenges associated with hip replacement in very young patients. There was kind of a resurgence, I think, in the literature devoted to the young patient with arthroplasty in the 2000s. From the 90s to about 2010, there wasn't very much devoted to this, and John Clohissey's to be credited, his group and several others in North America began to try and look at the results of hip replacement in these young patients with different functional expectations. This is a review from John's group, and he really pointed out that there's been an evolution of indications moving away from traditional inflammatory disease, which was really the cause of a lot of our early patients going on to joint replacement, and that's shifted now to patients who have predominant structural disease. Additionally, there's been a shift from cementless fixation, from cemented fixation to cementless fixation, and it appears that cementless fixation, particularly in this young active patient group, is more durable. We are seeing more consistent clinical results, and the failure rates have changed, so we see lower rates now of aseptic loosening and revision, and I think one of the themes that you'll see throughout this talk is that most of the problems that we see in the very young are related to the bearing surface. So this is just a couple other review articles in the last 10 years or so, again, kind of reiterating some of these same concepts. We looked at the 10-year survivorship in your upper left here, the 10-year survivorship of primary hip replacement in patients under 30 at our institution. We published that in 2018. And the teenage group of patients that I'm going to talk to you about today are a subset of that group. There's a recent publication again out of Asia that shows cementless fixation doing very well in patients under 30, as published in 2018 as well. This is probably the most pertinent registry study that was published in 2018. It was a review of the UK registry, 769 total hip patients under 20 years of age, mean 5-year follow-up. And what you see is an incredibly good survivorship statistic at 96%. And again, that important theme that most of the problems that we see are related to the bearing surface couple. So the dilemma with a lot of these patients is we understand that hip preservation is preferred, but unfortunately, we do see patients with advanced chondrosis, limited range of motion, functional limitations, and we have to consider total hip replacement. Many surgeons are uncomfortable thinking about doing total hip replacements in the very young, especially as we get into the teenage population. And one of my mentors, a huge mentor for many of us in North America, John Callahan, has emphasized to me many times that we probably have the most to learn in following these young patients, and I think we are trying to do a better job of that to really surveil them for a lifelong period of time. So this is the type of things that we can see in the very young patients. This is a 19-year-old male with a very severe case of MHE. This would, I think, even for a lot of arthroplasty surgeons, start to raise the anxiety level. This is just a case that we did fairly recently with a SROM stem, and just to give you an idea of the challenges that we see from the morphology side of things. So we wanted to look at this subgroup of teenage patients in that original group of patients that we looked at who were under age 30. So the goal was to evaluate outcomes of these patients using more modern implants in teenage patients treated for arthrosis, pain, and disability. So this was a retrospective review of all the patients under 20 that we treated from May 2004 to March 2015. The vast majority of these were my cases. And we importantly excluded metal on metal bearings in this group. In our first publication on the under 30, we included metal bearings, and obviously those were associated with a higher failure rate. So the series is comprised of 35 consecutive hips in 31 patients under 20 years of age. The average age was 16, with a range of 12 to 19. Importantly, 21 patients, or 75%, had previous hip surgery for underlying structural disease such as dysplasia, impingement, or the sequelae of pediatric hip disease. And we used, as you've heard a little bit in this meeting, we used the PROMIS scoring system to look at physical function, mental health, and global pain scores, and then we did an independent radiographic analysis as our primary outcome measures. So structural hip disease comprised 72% of the patients in this series, avascular necrosis 11%, and inflammatory arthritis, as we talked about, a shrinking indication at 17% for this series. When we look at the components that we use on the femoral side, we use 33 proximally porous coated stems, either a taper wedge stem or 10 modular SROM type of stems, one fully HA-coated stem, and one modular revision stem. All the acetabular components were contemporary hemispherical designs put in a press-fit fashion with or without screws, and all the bearing surfaces were ceramic on highly cross-linked polyethylene. So here are the demographics of that population. The mean age, as I said, 16.3. You can see the follow-up in the middle there is at 5.5 years. And if you look at the last two figures in terms of operative time, about 2 hours, which for us is a little longer than we would typically take for a primary, which I think indicates some of the technical challenges in this group of patients. And similarly, blood loss is a little higher than a comparable group of more straightforward osteoarthritic patients. So the average follow-up at 5.5 years. The results are that we have had to revise one patient for deep infection who required a 2-stage process and eventually resolved his infection. 34 of 35 of these hips continued to survive. We did one superficial IND, and there's been no aseptic loosening, dislocations, periprosthetic fractures, neurovascular injury, or other medical complications in this group. In terms of radiographic results, the acetabular position is pretty much what you would expect in terms of trying to hit the target, average of 42 degrees of abduction and an average of 28 degrees of acetabular anaversion. When we look on the femoral side, the results look very good, very low rates of radiolucencies with these proximally porous coated stems, and similarly on the acetabular side, very low rates of radiolucency. And all of the components, all these titanium porous coated components appear to be bone ingrown on radiographic follow-up. The clinical results, I think, are important. So using the PROMIS system, where a score of 50 is equivalent to the average US population in terms of function or pain or mental health, we get very close to meeting the average. So the mean physical function score was 48 out of 50, the mean mental health score was 47, and the global pain score was 2.9 with a range of 0 to 8. Here's a couple case examples. This is a 19-year-old male. You can see he has sequelae of CDH or DDH, developing osteonecrosis. This was a total hip that I did at age 19. You can see 28 millimeter head, SROM stem. At 20-year follow-up, the patient was asymptomatic despite having fairly pronounced polyethylene wear, and we continue to follow this person, and at some point we will do an isolated polyethylene exchange. Here's a 14-year-old female that I first saw on the left at age 14, and then had her hardware out, and at 17 you can see her film on the right with fairly advanced arthrosis. This is her at 6-week follow-up, and she's the type of patient that I remember very distinctly. She was incredibly disabled. She's a beautiful teenage girl when I saw her, and she was incredibly distraught. You can see her 12-year follow-up film with polyethylene wear, and then we did a polyethylene exchange, and here she is 3 years after that, so now 15 years on her original components. But I still see her every couple of years, and she's now a mom, and she comes in with her kids, and she's lived an incredibly functional life, and I think is very, very grateful for this intervention. So if we go back to the literature, this is kind of what I would think are the key studies describing the results of patients of total hip replacement in patients in the very young. You can see the series in general are fairly small, but what stands out is, in general, the aseptic loosening rate. The rate of revision for aseptic loosening is fairly low. When we look specifically at the results of our patients under 20, comparing those to the results of patients who are under 30 in that original publication, you can see the reasons for revisions are very, very similar between the two groups. But when you look at the physical function measurements, basically the clinical and functional outcome in the patients under 20, comparing them to the patients who are under 30, we actually see the results are a little better in this very, very young group, and whether that holds up over time is a very good question. But in conclusion, I think cementless total hip replacement in the teenage patient with structural hip disease and arthrosis is a highly successful intervention at 5 years. Modern cementless designs have minimized component loosening as a cause of failure, and certainly lifelong surveillance is encouraged to monitor polyethylene wear. Thank you very much for your attention.